I think we should start.
Okay, good. Good morning or good afternoon or good evening to all of you, depending on wherever you are. And welcome to the POCUSNEO Symposium series. And this is the 7th symposium. And it is one of the largest symposium with the participants number that we ever conducted. And welcome. And let me introduce myself. I'm Dr. Muzaffar Ghani Abdul Wahab. Call me as Ghani. I'm the co-chair and founder of POCUSNEO. And I'm an associate professor and neonatologist at McMaster University. It's my pleasure to introduce Dr. Yasser El Said, who is the co-chair and founder of POCUSNEO and Neonatal Academy, and he is an associate professor in neonatology from University of Manitoba, Winnipeg. And welcome, Dr. Yasser, to join me. And it is my pleasure to thank the Medtronic whole team. This is both the global and Canadian companies, for providing us with the greatest support with the unrestricted grant for conducting such a valuable event to the whole entire globe. And thank you, Medtronic. And with that request, we just wanted to tell the audience, please visit the exhibitor booth, which is located on your screen on the top left corner. You can see exhibitors and visit Medtronic. And there are valuable information, videos and articles are there, regarding the NIV technology. Please visit and don't forget. And it will be there even after the session is ended on our microsite. And let me thank our executive committee, patrons and advisors and international collaborators, our media, administrative and technical teams to make our functions carried out without any interruption throughout the globe and continuously over the years. And this is a largest virtual event, what we have conducted with more than 1,456 participants registered to this symposium. And they are from total of 102 countries in the globe. And we have reached 14,000 members all around the globe. And we don't have any country without our POCUSNEO and our NeoPEDS Academy member. And with that small introduction to our group, I just wanted to say, everyone, this is a new platform. And just we have moved this one because of a larger number. And this platform is meant for multi-session. So you are now connected to session number 1. And please stay connected. Do not jump to any other sessions. There is nothing else. All the other sessions will not be active. Only this session we will continue. Entire sessions, the whole 2.5 hours will be conducted in this link only. So you do not need to leave this session. And please type your questions in the Q&A section only, which you can find on the top right corner, Q&A. And please refrain from asking for microphone to speak. There is a button to ask for microphone. Please do not ask. We have largest capacity audience and is unable to provide the mic to the audience at this moment. And our panelists and speakers will be reading and answering your questions if you type in Q&A section. And for any other technical assistance, please email to support@pocusneo.org. And our team members will be helping you, assisting you for any IT related issues. And it is my pleasure to announce the upcoming conference we are going to hold in Toronto, closer to the PAS. It is a pre-conference, that is a pre-PAS day. This is May 2nd. So PAS is between May 3rd to 6th. And it is a one-day event we organized to optimize the knowledge translation among the ventilation in newborns. And this will be conducted in Toronto on May 2nd. Please save the date, and further information we will be sharing with you by Monday next week. And this is the flyer, just I want sharing, like we get a cheapest registration cost to, even it will not cover the expenses of what we are going to conduct. At that level, we have minimized. So please make use of it. And it is a super early bird offer, which ends by December 31st. Please register as soon as we announce, because we have limited capacity of the seats. And this is the agenda, one-day agenda, which includes the attractive topics from the legends in neonatal ventilation from USA and Canada. And we have 5 major workshops, which is a part of the registration together. So get enrolled as soon as possible. Please, make your seat as soon as possible to avoid dissatisfaction when we finish the registration. And these are the workshops in that conference. Okay. And also, just you are aware of NeoPEDS Academy, and which we are hosting all the courses, the workshops, conferences, symposiums. All the informations are there. Please visit neopeds.academy. And the featured courses you can take anytime: the lung ultrasound courses, basic and advanced, and the point of care ultrasound courses, hemodynamic courses, and ultrasound guided vascular access, or NIRS, and much more and more. Like we are going to launch 4 to 5 courses per month. And you are aware of the institutional diploma program we have introduced since a couple of years. So it's going on very well, and right now we have restricted to the institution. So if your institution have 10 or more physicians who wanted to enroll into the diploma training program, please contact us, and we will get back to you and with the timing and the training program structure. With that, I'm passing the mic to my colleague, Dr. Yasser El Said, to introduce the panelists. Yasser.
Thank you, Dr. Muzaffar Ghani, for this introduction, and welcome everyone, wherever you are. It's my pleasure to introduce our 4 wonderful panelists for today. Dr. Adil Mohammed is Associate Professor of Pediatrics, University of Toronto, and one of the Canadian known experts in point-of-care lung ultrasound. Dr. Hanifi Soylu is Professor of Pediatrics at Selçuk University, Konya, Turkey. Unfortunately, he is sick today, and he could not join us. Dr. Nadia Ben Fadel, Associate Professor of Pediatrics, University of Ottawa, and Program Director of Neonatology Fellowship Program, and also Target Neonatal Echocardiography Program. And Dr. Samer Yousfi is a clinical instructor of pediatrics and a neonatologist at Surrey Memorial Hospital and University of British Columbia, Vancouver, Canada. Thank you, everyone, for joining us today, and I hope everyone enjoy the educational session and the discussion at the end. So now the floor is yours, our great panelist, to introduce the first speaker.
Thank you, Dr. El Sayed. Good morning, everyone. Good afternoon. Good evening. It's an honor and a great pleasure to first introduce our first speaker, Professor Ramanthan. Dr. Ramanthan is Professor of Pediatric and Neonatology Head and Fellowship Program Director at Keck School of Medicine, University of South California. Dr. Ramanthan is well known for his interest in surfactant therapy and non-invasive ventilation and oxygen toxicity. And today, the talk will be about non-invasive ventilation in preterm infant. Dr. Ramanthan, thank you so much for the session in advance. It's all yours. Thank you.
So Dr. Ram's talk is already recorded, and I'm going to share the recorded session now.
Good day. I'd like to thank the scientific committee for inviting me to the 7th POCUSNEO Advanced Neonatal Care Symposium on Non-Invasive Ventilation in Preterm Infants Clinical Guidelines. Conflicts of interest disclosures. I'm the inventor of RAM nasal cannula and have a joint patent with the Neotech products. If I receive any honorarium, I donate all of it to charities to help mothers, newborns, and children globally. I also founded a not-for-profit organization called Breathe for Babies Inc. to raise funds to donate the ROMS Meta ventilator pending FDA approval. This will deliver bubble CPAP, bubble NIPPV, bubble IME in low and middle income countries. I typically do not teach how to intubate babies, I only teach how to extubate babies. My objectives are fourfold. One, describe the use of NIPPV as a primary mode in the delivery room and in the NICU in preterm with respiratory distress. Clinical guidelines to set up NIPPV in preterm infants during the acute phase of respiratory failure as well as during evolving or established bronchopulmonary dysplasia. Explain the rationale for setting up the peak inspiratory pressure, positive end expiratory pressure, inspiratory time, and the rate during NIPPV. Finally, describe the weaning strategies during NIPPV or nasal intermittent positive pressure ventilation. Things to consider during NIPPV support are: 1. What type of a nasal interface to use to deliver NIPPV in the delivery room or in the NICU. Devices to deliver NIPPV. Bubble NIPPV still not available as of now, but ventilator delivered NIPPV is the most common modality for delivering NIPPV. Key settings during NIPPV. What peak inspiratory pressure should be set? What minimum positive end expiratory pressure once it's set? What is the inspiratory time and what is the rate? Care of the baby during NIPPV to minimize nasal injuries and maximize patient comfort and care provider comfort, including families, for example, during kangaroo mother care. So the number of non-invasive modes are available. I am going to solely focus today on NIPPV, which truly mimics invasive ventilation without an endotracheal tube. CPAP works, but failure rates are high. I'm not going to discuss about that today, including high-flow nasal cannula. I'm not discussing that in this conference. So let's look at the interfaces for use in the delivery room. This is a systematic review and meta-analysis published from Melbourne, Australia, looking at 5 randomized controlled trials, 1,225 babies. They looked at multiple interfaces like Leerdahl, Fisher and Packel, Resusciture, Armstrong, Rendell-Backer, anatomical intersurgical, Leerdahl, SnapFit, Ohio, and AMBU. So they concluded that there is little high quality of evidence for choosing an interface to provide positive pressure ventilation after all these years of resuscitation using these masks. Binasal cannula appears to offer some advantages over face masks, but needs further testing. So the interfaces typically used in the delivery room on the NICU are face mask, Argyle prongs, Hudson prongs, Inca prongs, nasal mask, or Neotech RAM nasal cannula. Which is basically a nasal cannula, binasal prong designed like a nasal cannula with a 15 millimeter adapter that will attach to a bag, attach to a T-piece, attach to a conventional ventilator, or even high frequency ventilator. Let's look at the data. What is the problem with face mask? This is using a respiratory function monitoring. Dr. George Smolser from Canada published this paper. Then he looked at what happens with airway obstruction and mask leak during face mask resuscitation. 56 babies were studied. So he showed that airway obstruction from the tongue falling backward and obstructing the hypopharynx, defined as a 75% decrease in exhaled tidal volume, happened in 26% of the babies. Mask leak around the mouth happened in 51% of the babies. So he concluded mask leak and airway obstruction are very common, especially in very low birth weight babies with a face mask resuscitation. It's another study from Netherlands looking at effect of face mask on breathing pattern in 429 preterm infants less than or equal to 32 weeks. Again, They used a respiratory function monitor. They showed that when you apply a face mask, it triggers the trigeminal cardiac reflex, or TCR, from the mandibular branches of the trigeminal nerve. So when you apply face mask, due to this reflex, 54% of the babies became apneic, developed bradycardia and desaturation. So they concluded that avoiding sensitive area around the mouth by using an alternative interface like nasal prongs may reduce the risk of inducing TCR, or trigeminal cardiac reflex. So there are some potential advantages in the RAM cannula over mask ventilation in the delivery room. Number one is dead space, because we do not use, when you're sending gas through the nasopharynx and closing the mouth, you're basically eliminating oropharyngeal or oral dead space. Second, there is less chance for trigeminal cardiac reflex. And third, less leaks. There are no leaks around the mask. That happens here, less leaks. So let's look at some studies. So again, these next two studies I'm going to show you are from my center, and this is a retrospective study of our experience. We published in the American Journal of Perinatology earlier. 270 to 4.6 kilo, 102 babies that were consecutively resuscitated with a RAM nasal cannula. Gestational age range from 23 to 41 weeks. 20% of the babies were less than 1 kilo. Again, need for chest compressions were only 5%. Intubated in the delivery room, 8% of the babies. Pneumothorax seen on incidentally chest x-ray was 5%. None of the babies required chest tube or thoracentesis. Ensure intubation surfactant extubation was used in about 27% of the babies. Remember, these babies' mean birth weight was 2.1 kilo, mean gestational age was 32 plus or minus 5 weeks. A second retrospective study from our center, where we looked at using CPAP versus NIPP in the delivery room. These are mean gestational age about 27 weeks, mean birth weight about 900 grams, very similar. We showed that intubation, delivery room intubation or emergency room intubation in the DR or chest compressions were all significantly lower if you resuscitate a baby in the delivery room using NIPPV compared to nasal CPAP. We also showed babies that required intubation by 24 hours of age was also significantly less, 38% compared to 66%. Even if the babies were intubated, the median duration of intubation was 11 days compared to 2 days. Again, surfactant was given in 90% of the babies because these are 27-week mean gestational age. We showed that it's safe, feasible, and effective, however, not a randomized controlled trial. Let's look at the randomized controlled trials of using CPAP in the delivery room versus intubation. There have been 8 randomized controls that have been published from 2008 to 2013. TPAS from Netherlands in 2007, COIN trial from Colin Marley et al. From Australia, New Zealand, Rojas from South America, CurePAP trial from Italy, Support trial from the United States, Vermont Oxford Network trial again from US, and Gopal from Germany and from Turkey, Ankara. So in every single study, need for early mechanical ventilation within the first 5 days of age in babies randomized to nasal CPAP in the delivery room happened 33 to 52% of the time babies failed. Younger the gestational age, higher the failure rate. In the support trial, 34.4% of the babies didn't even get out of the delivery room and they got intubated. Prior to discharge from the NICU, babies that were randomized to nasal CPAP, 83% of the babies got intubated sometime in the NICU if they were maintained on nasal CPAP. How about CPAP versus NIPPV? Again, 10 randomized controls have been published from 1999 through 2016, either as a primary mode of respiratory support or following a period of mechanical ventilation. When the babies are extubated, they are randomized to CPAP or NIPPV. We published the first trial in 1999. Dr. Friedlich was the first author of this paper. Keith Barrington from San Diego, Kala from Philadelphia, Guggen from Israel, Moratti from Rome, Kishore from India, Lista from Milan, Menses from South America. Again in 2012, we published a 5-center trial from US, Onkel from Turkey. Every single study, every part of the world, failure rates with NIPPV were much less, significantly lower, 5 to 25% compared to 33 to 53% I just showed you. So clearly, NIPPV when used as a primary mode or a following period of ventilation is more effective.
I'm so sorry. I do get messages that people cannot see the slide. So if it is so, can you please type on the chat, please? If not, we can go with the live session. So people can see. I don't have any problem. I can see the slides. Okay, perfect. So we'll continue. I'm so sorry to interrupt.
To 33 to 53% I just showed you. So clearly, NIPPV when used as a primary mode or a following period of ventilation is more effective in decreasing failures and requiring intubation or reintubation compared to nasal CPAP. Let's look at the systematic review and meta-analysis. This is Ferguson from Melbourne. They looked at synchronized or non-synchronized NIPPV versus nasal CPAP. Both are effective. However, it's more effective with synchronized NIPPV. This is our trial in 1999. And they show that the relative risk ratio was 0.25, confidence interval 0.15 to 0.41 in synchronized NIPPV. Look at non-synchronized NIPPV. It's still statistically significant decrease in the need for intubation. Risk ratio 0.64. Confidence interval does not cross 1. Kirpalani's trial, which is considered a mixed trial, mostly it's a CPAP trial where the confidence interval crosses 1, so it's not significant. So when they looked at different interventions to improve successful extubation in preterm babies, they looked at NIPPV versus nasal CPAP. You can see the risk rate is 0.70. Number needed to treat 8 babies. 95 confidence interval, 5 to 13 babies. If you manage on NIPPV, you reduce need for 1 intubation. Non-synchronized NIPPV or BiPAP or CPAP, nasal CPAP, 8. If you look at synchronized or non-synchronized versus nasal CPAP, the number is still great. 4 babies to prevent 1 extubation failure. So they concluded that preterm babies should be extubated to non-invasive respiratory support. Caffeine should be used routinely. However, NIPPV was superior to nasal CPAP in preventing extubation failure. Lemry from Canada also published in a Cochrane review and meta-analysis of 10 trials, 1,061 babies. She concluded that early NIPPV does appear to be superior to nasal CPAP alone for decreasing respiratory failure and need for intubation endotracheal tube ventilation in preterm babies with respiratory distress syndrome. So in the acute phase of RDS, NIPPV is superior to nasal CPAP if you want to avoid intubation. And recently, Ramaswamy et al. Published a systematic review and network meta-analysis of 35 studies, 4,000 plus babies, looking at for primary respiratory support, CPAP versus NIPPV. So they concluded most effective non-invasive ventilation mode of respiratory support in preterm with RDS was NIPPV. If you look at NIPPV result in lower incidence of BPD or mortality when compared to nasal CPAP, risk ratio 0.74, confidence interval less than 1. He also looked at post-extubation. After a period of mechanical ventilation, when you extubate the babies to different modes of non-invasive ventilation, what happens to them? Again, 33 studies, 4,080 babies, large number. Results of this network meta-analysis indicate that synchronized NIPP might be the most effective. Continuous flow CPAP, like bubble CPAP, is the least effective modality in preventing extubation failure in preterm infants. If you look at synchronized or non-synchronized, both are statistically significant decrease. You can see confidence interval is here. Both of them do not touch. Bubble CPAP or BiPAP, high flow nasal cannula, they all cross 1. Okay, so I think I convinced you that NIPPV as a primary mode of respiratory support in the delivery room or in the NICU superior to prevent extubation failures, right? What are the controls and limits when you are managing a baby with acute lung disease. Baseline CPAP level or P of 6 we recommend, side pressure or PIP of 20, and duration of high pressure should be longer because the resistance of the interface are higher. Therefore, you need to use a longer inspiratory time. We typically use 0.5 seconds, and number of breaths is 40, and flow rate is set by the machine. If not, 3 to 4 times the size of the endotracheal tube. So we typically start at 20/6, rate of 40, and inspiratory time of 0.5 seconds. Adjust the FiO to target your saturation. In babies with severe BPD or established or evolving BPD, you may have to use much higher peak inspiratory pressures than PEEP. For example, PAP of 30 to 38, PEEP 6 to 10. Some centers have used even higher settings. Remember, if you're worried about using higher pressures, then NIPPV will definitely fail. So this is typically what we start, and then we adjust up or down based on the chest X-ray or FiO2 requirements or blood gases. Interestingly, Mark Weems et al. From Tennessee, it's a very busy NICU. They presented an abstract in the Children's Hospital Neonatal Consortium, CHNC, recently, about 2 months ago, where their goal was to prevent tracheostomy in babies with severe bronchopulmonary dysplasia. So they looked at that. They were around 61 weeks of postmenstrual age. They set a peak inspiratory pressure of 45, and a PEEP of 14, rate of 40, and inspiratory time of 0.4 seconds. You remember, in chronic babies, just like chronic phase ventilation for BPD babies, they have airway disease, the airway collapses, so you want to keep the airway open by using higher end expiratory pressure. That's exactly what they did even in the non-intubated babies, NIPPV, so they use rate of 40. So slow weaning after a month of stable course, over a 10-week period, they decreased the peak inspiratory pressure to 25 and then extubated the baby to low flow cannula. They used the RAM cannula in this, and they used a conventional ventilator, not synchronized, non-synchronized. So they were able to decrease the need for tracheostomy in a significant number of babies, shorter length of stay, and much easier for the parents to take care of this baby at home. So why do we use higher pressure? Here is a study, small study, 15 babies, many years ago, published by Agai et al. So they looked at about 29.5 week gestation, 4-day-old babies, 1.3 kilo, looked at tidal volume. This is babies on nasal CPAP. This is 10/5. This is 12/5. This is 14/5. They increased the peak inspiratory pressure, so the delta pressure was increased progressively by 2 centimeters. And they show workup breathing, inspiratory workup breathing was significantly lower when you increase the peak inspiratory pressure. Elastic workup breathing, resistive workup breathing, all of them are significantly lower. So ventilator delivered peak inspiratory pressure during synchronized NIPPV decrease the workup breathing. That's another reason why we like to use higher peak inspiratory pressure. What about rate? Why do you want to use a higher rate compared to intubated babies? Here is the data from Chang, from Eduardo Bancalari's group in Miami. They looked at efforts synchronized versus non-synchronized IME versus nasal CPAP. They tested at different rates. They showed that inspiratory effort during synchronized NIPP at a faster rate, at 40, was much more striking. So in other words, these are only 16 patients, birth weight about 993 grams. Both during synchronized and non-synchronized NIPPV, respiratory unloading was much more striking at higher rates than at lower rate. This synchronization did not affect tidal volume, phase angle, or apnea or hypoxemia. Again, as I mentioned before, if you have synchronized NIPPV, go ahead and use it. If you do not, it's still better. And the reason we want to use higher rate is to unload the respiratory effort by the baby. Also, most of these babies have shallow respiration, so you want to just support the baby a little bit with a backup rate. That way, they have much less desaturation at bradycardias. What about ITAP? Why do I recommend 0.5 seconds? It's an in vitro study looking at 0.3 versus 0.5 using different prongs, Fisher, Medicampbell, or Neotech. So when they increase the inspiratory time from 0.3 to 0.5 seconds, keeping the delta pressure constant, no change in PIP, no change in PEEP, you can see the amount of tidal volume delivered is significantly higher, 14 versus 22. In this study, 14.7 versus 25.3. So longer ride time results in higher delivery of tidal volume, and therefore you want to use a long inspiratory time. The other things we have to worry about during nasal ventilation, whether CPAP or NIPPV, is the injury to the nasal mucosa or septal injury. Here is a paper from Ohio where they looked at normal, nice pink mucosa, little bit of ulceration, granulation tissue, moderate to severe, 55% of the, more than 50% of the nasal passage is blocked. Columnar necrosis. Just after, this is 10 days, they saw early necrosis. 2 days later, completely collapse of the columella. That happened in 5.5% of the babies with columnar necrosis. 13.2% of them had mild to moderate panel D and E type of vestibular stenosis happened in their unit. A second study from Switzerland, very similar. Nasal injuries with binasal prongs. You can see a little bit of erythema. They tried to alternate with binasal prong versus mask. You can see a little bit of ulceration, and here is deep ulcer. So that happened in 42.5% of the babies on nasal CPAP. So 30.6 cases per 1,000 days of nasal CPAP. So you have to be very, very careful when you are using any mode of NIV, CPAP or NIPPV. So some of the practical issues during NIPPV are, you want to minimize septal or columnar injury, and if there is mucosa is injured, you increase the risk for nosocomial infections. So stay away from the columella, this part of the nose. So make nose rounds, what we call it. Use a septal guard, I'll show you in a minute. When fixing the nasal canal or nasal interface, make sure there is a gap between the columella and the nasal interface. May use a pacifier to minimize the leak with open mouth, because babies are obligatory nose breathers. Here is the micropremi that we use, where there is a baby under phototherapy. Here is another baby. We use a NeoSeal to decrease the leak and also create a gap between the columella and the interface. Sometimes use an offside to make sure it stays there, then it comes out. And chin strap we occasionally use if the baby is really having trouble in ventilation. What is the data? Here is the 3 randomized controlled trials I'm going to show you. This was published from Israel, comparing ram nasal cannula versus binasal prongs to deliver NIPPV in preterm infants 24 to 34 week gestation. You can see similar birth weight, similar gestational age, intubation within 72 hours, no difference. 14% versus 18% with the binasal mask or prong. PIP, PEEP, and respiratory rate were similar. BPD, no difference. Neck, no difference. Time to full feeds, no difference. Time to discharge, no difference. The only thing they found was moderate to severe nasal injury was much lower, 5% versus 17% in the prong or mask group compared to the nasal cannula group. A second randomized control was published from India, where it's very similar, now bigger babies, 28 to 34 week gestation. They used Hudson prong versus ram cannula using a cannulate to protect the nose, and they showed that ram cannula with cannulate compared to Hudson prong decreases nasal injury without increasing the need for mechanical ventilation. They found 5.4% nasal injury compared to 26.4%. The third trial, again from India, published in European Journal of Pediatrics, it's a larger trial. This is using CPAP, not the NIPPV like the previous 2 trials. They showed in the low and middle income country, ram nasal cannula versus short binasal prongs. Again, equally effective. Intubation within 72 hours, not different. Intubation at any time during the NICU was not different. Duration of CPAP, in fact, was less the ram cannula. Moderate to severe nasal injury was significantly less, 2.4 versus 8.7. Time to discharge was not different. Okay, so I mentioned, how do we start? We start with 20/6 rate of 40 an item of 0.5 seconds. When the FiO2 is less than 40, and the PCO2 is less than 60 or even 65, pH is over 7.25, we will start weaning the peak inspiratory pressure first, and then PEEP, finally the rate. Of NIPPV, when the PIP is less than 15, PEEP is around 5, rate is 20, and FiO2 is below 30%, we switch the baby to nasal CPAP, and then off nasal CPAP, and the CPAP pressure is equal to or less than 5, to low flow cannula, less than 2 liters per minute. Again, when we change from NIPPV to CPAP to low flow cannula, we try at least 24 hours in each of these modes to make sure baby is doing well. We also know that CPAP does promote lung growth. Hypercapnia, permissive hypercapnia, actually activates the glottic dilator muscle and opens the larynx in neonates during NIPPV. So here is some papers that was given to me recently when I was in Tanzania, a NICU's journey in Arusha Lutheran Medical Center with bubble CPAP using ram cannula and kangaroo mother care. And they started interventions where they started ram nasal cannula here, and then they showed survival rate improved from 82% to over 93%. Okay, it can be done safely, effectively, even in low and middle income countries, with minimal training on how to use NIPPV. They actually use mostly bubble CPAP. Lately, they are using bubble NIPPV with a new ventilator called NeoVent. What about pressures? I think the future is bright for NIPPV because all this time we don't know what pressure the baby is getting at the interface. A ventilator like Puritan Bennett actually calibrates the interface, whether ram cannula or Hudson prongs, Inca prongs, and then you attach to the ventilator. It actually tells you what is the pressure at the interface. So in this baby, it's actually a tracing from one of our babies, I set the PIP of 20, PEEP of 8, and what did the baby see? 20 over 7.8 PEEP. This is exactly what patient sees, and the leak is about 0.4 liters per minute. There is no more guesswork. So how do we use ram cannula? So why do we want to have a leak? I always recommend 20 to 30% leak. Why? One, to reduce expiratory resistance. Babies are going to breathe through the nose. They're not going to breathe out through the mouth because babies are obligatory nose breathers until about 4 months of age. Second, you want to minimize the nasal injury. Remember, even in intubated, you have leaks around the trachea, right, to avoid injury to the trachea. We rarely ever use cuffed endotracheal tubes for the same reason. You want to have some gap. Same thing, you want to have some gap in the nasal interface. What about feeding position? You keep it midline during the first 3 days to avoid IBH, but later on, here is a nice study that showed that you have to aspirate air from the stomach before each feed. Avoid right lateral position. If you're going to put the baby on lateral position, left lateral is better, because in this study they showed that the risk for GE reflux is much, much higher within 2 to 4 hours. It's a liquid reflux or mixed reflux, gas reflux on the right lateral position compared to left lateral position. If you have to turn the baby on NIPPV, you're better off either in supine or left lateral position to minimize GE reflux. So I think time has come. This is my last slide for NIPPV in preterm babies. It can be used as a primary mode or a following period of invasive mechanical ventilation to decrease the need for intubation and mechanical ventilation and less BPD. Limited number of randomized clinical trials shown a decrease in death or BPD with NIPPV. Number needed is 7. Safe, feasible, effective, easy to implement. Failures are very similar with CPAP versus BiPAP or CiPAP or DOAPAP. Nasal high-frequency jet ventilation may be used as a rescue mode. I did not talk about that today. Future, I think LISA or SALSA, supraglottic airway administered surfactant, followed by NIPPV. If you have any questions, this is my email, drramanathan@gmail.com. Thank you so much for your attention.
Thank you, Professor Ram, and thank you all the audience. I feel there are few people who could not see the slides, And some could like solve the problem after logging out and logging in. And if you have logged in through a mobile device, you cannot see the slides. So please follow the instructions what I have sent along the email. So you must use either Chrome or Firefox as the browser, and there is a privacy setting need to be enabled. That's why we have sent the clear instructions before even you are logging in. Kindly follow those instructions and you are able to see the slides or the shared screen. If you still had any issues, and please please type in the chat, and just to specify which system you are using, we'll try to give you some solutions from the back end. The worst case scenario, all these sessions are recorded and it is available for you to watch after the session is over. And we will provide you with the access, so don't worry about if you are missing some part. Thank you so much. And Adil, are you there?
Yes, thank you so much, Gani, and thank you so much, Dr. Ram, for the very interesting and presentation, as usual. It's my honor now to introduce Dr. Robin Alvaro. Dr. Robin is the Associate Professor of Pediatrics, Division of Neonatology, University of Manitoba, and the head of the Sleep Lab in Manitoba, Winnipeg. Dr. Robin will talk to us today about the challenges in non-invasive ventilation in preterm infant. Dr. Robin, please, the stage is yours.
Thank you, Dale. And let me share the screen.
Are you able to?
Yeah, can you see the screen?
Yes, you can put in the presenter mode, please.
Yeah, I did already. Done.
No, still not in the present. Yeah, it is in the slides view. So
yeah, it's showing the presenter view already on my computer. You want me to try again?
Yeah.
Okay, let's see. Okay. Can you see that now?
Still in the slide view. So can you
yes, sir.
In the bottom, that can you click on the presenter?
I did already. Yeah, that's what I see in my screen. It's the presenter view on my screen.
Alvaro, do you have two screens? Maybe change to the other screen in your camera.
Okay, let me see. Entire screen?
Yeah, even you can do entire screen.
Okay, that's okay. So I'll go to the slideshow.
Yeah, but still it's not working.
Okay, that's what I'm doing. Yeah, it shows in the slideshow mode in my screen.
Okay, so can you do on top? You see on the top left hand side, there is a the presenter symbol is there. Can you click that one above the home?
Above the home.
Above the home, there is a after that there is. Can you click on that?
I don't see that. Okay.
So you know what? I can share the screen with your presentation.
Okay, and I'm gonna be able to
navigate.
Okay.
Yeah.
Okay. So maybe Yasser is here. I'll see. Okay. So okay, stop sharing. Okay. Share screen. Window. Okay. Share. And then yeah, home. This one.
Yeah, start from the beginning. Okay.
Can you see now the
No.
full screen?
No.
No, that's what I did already.
Yeah.
At the bottom, the third one is full slide.
Close this one, so it will give us like more room on your right side.
That's right. Yeah.
This column, unnecessarily one, the animation one.
Where? No, this is the only one. Can you see the slideshow now?
No. Do you have a dual screen?
No.
Okay. We couldn't see anything.
Do you want to stop sharing, then reshare?
That I did that already.
Okay.
For a PowerPoint presentation, there are the options. Rightmost is the full slide presentation.
No, start screen doesn't allow me to.
No? Okay.
If I go share from here. Can you see that now?
Still in the slides view.
Yeah, but I don't know if that's gonna.
So do you want me to share your presentation?
Yeah. So are you gonna be able? I'm not gonna be able to move the slides, right? The animation.
Oh, animation is the important. So
okay, Yasser, do you want me to try to see if you can do it on your computer? Okay, let me see if I can do it on Yasser's computer.
Yep.
Oh, okay, sure. I mean, Yasser is gonna bring his computer and see if we can do it here.
Yeah.
Should we use this time to ask?
Yeah. Maybe some
questions?
Yeah. Please. Yeah. Okay.
Okay. Dr. Ram, this is connect.
Yeah. Hi, Dr.
So one of the questions that came across was the mask versus the bronch, and especially in the delivery room, and looks like the mask is better from what we are seeing. Or we still recommend that we can use the bronchs. And here I'm not referring to the short or the actual RAM bronchs.
Yeah, that's what we use in our
light on this one would be great. Yeah.
That's exactly what we used in the last 10, 11 years. So we attach the RAM cannula to the T-piece resuscitator, and then we use our finger if the baby needs NIPPV. If not, baby gets straight CPAP. We set it at 6, 20/6 on the Neo piece. It could be disposable one, or it could be the one that's fixed on the radiant warmer. The studies have shown that applying the face mask in the delivery room, because of the trigeminal cardiac reflex, they become apneic or bradycardic 54% of the time. That's a study from Netherlands. That's the reason why we want to use in the resuscitation, in the delivery room itself, we want to avoid the sensitive area around the mouth. So just put the cannula, close the mouth, and then start giving NIPPV or just straight CPAP. The baby doesn't have a backup rate.
They might be referring, Dr. Ram, to the nasal mask, not the whole mask that covers nose and mouth. It's only the nasal mask to avoid the trauma to the nasal bridge.
Yeah, the nasal mask, issue is in the delivery room, you need to have a special setup, right? So you can't use the T-piece attached to the nasal mask. So that's the problem. Most places you have the T-piece or a bag, so you could easily adapt if you're using prongs rather than the face mask. And the difference in leak between pressure at the hypopharynx is only 0.5 to 0.6 centimeters between the mask and prong and the cannula. That is the reason we said instead of 5, we use 6.
Okay.
Thank you so much, Nadia.
Dr. Ram, there's another question from Dr. Arjun Day, asking the question, is it possible to wean from NIV to low flow directly? And how about high flow instead of CPAP as a weaning mode?
Yeah, I had responded on the chat. The problem with the high flow weaning is I don't know what the pressure the baby is seeing, and I have no control. So especially in preterm babies. In bigger babies, you can switch to high flow. I mean, I don't know what the definition. We know for low flow, less than 2 liters per minute. High flow could be 4 or 6 liters per minute. and the pressures are quite variable. You can get 9 or 16 centimeters a peak, even at 6 liters per minute. So that's the reason why I don't like to use it. I think Dr. Ruben Alvaro's talk is ready to go. So I'll respond at the end during the panel discussion. Thank you so much.
Thank you so much for filling this gap for technical issue. Dr. Ruben, are you ready to present?
Ruben, you are muted.
If you can turn on the camera, Dr. Ruben, and
Yeah, I can speak now.
Okay. Can you hear me now?
yes, perfect.
Okay, and you see the
And we
slideshow?
can see the slide very well too. Yeah.
Okay, perfect. Okay. Okay, well, thank you very much. Sorry for the technical problems. Thank you very much for allowing me to present this 7th POCUSNEO Advanced Neonatal Care Symposium. And whenever you are, good morning, good afternoon, good evening. So the title of my presentation today is NIV Clinical Applications and Management Algorithms. So I have nothing to disclose. And the objectives of today's presentation will be first, to identify the basic principles of non-invasive ventilation. Second, to describe the different types of non-invasive devices. Third, to describe the advantages and limitations of non-invasive ventilation in preterm infants. And finally, to identify the indications and management algorithm of NIV. So we know that there is a strong association between bronchopulmonary dysplasia and mechanical ventilation. We know that mechanical ventilation produces harm to the lungs by several mechanisms that include volume trauma, atelectal trauma, and just the presence of the endotracheal tube can cause increased risk of infection, inflammation, and airway injury. So one of the best strategies to prevent BPD is to try to avoid or shorten the duration of mechanical ventilation in favor of other non-invasive form of respiratory support than assist more than control ventilation in these preterm infants, with the goal of having fewer complications and better outcomes by avoiding mechanical ventilation. So we know that a nasal CPAP used early and prophylactically in the delivery room, together with rescue and early surfactant, decreases the incidence and severity of bronchopulmonary dysplasia. The mechanisms by which CPAP decreases lung injury is manifold, and this strategy needs to be used very early in life to be protected. So we know that CPAP develops an effective FRC, or helps to develop an effective FRC. We also know that CPAP reduces atelectal trauma, improves oxygenation, decreases airway resistance, splints chest wall and airway, improves surfactant metabolism, prevents intrapulmonary shunt, and finally also we know that CPAP decreases work of breathing. Now, and also helps to produce regular breathing. Now, what's the problem with CPAP? Now, according to the study done by Morley published in New England Journal of Medicine in 2008, they randomized babies to be prophylactically intubated and received surfactant, or be placed on nasal CPAP and received surfactant as a rescue mode. And in the group that were randomized to prophylactic CPAP, as you can see there, even when these babies were put on CPAP, babies under 26 weeks, 55% of them needed to be intubated because CPAP was not enough. And even in the group of 27 to 28 groups, up to 40% of these babies failed CPAP and needed to be intubated. So despite early use of CPAP and rescue surfactant, a high percentage of neonates will develop respiratory failure and will need to be intubated. And in many of these babies that are intubated and needed to be extubated later, they will also fail extubation. And that's why in the last several years, there have been a lot of research trying to develop better forms of non-invasive ventilation, try to see if we can decrease the number of babies that need to be intubated or number of babies that need to be reintubated. So what's NIV or nasal non-invasive ventilation? We know that CPAP remains the core element of all strategies of NIV. It's a mode of respiratory support that increases alveolar ventilation without the need of endotracheal access, either by intubation or tracheostomy. And it's a form of nasal CPAP in which we superimpose either non-synchronized breath, or called NIPPV, or synchronized breath, SNIPPV, that are delivered by the ventilator, either on a time cycle, in the case of non-synchronization, or synchronized with the infant's respiratory efforts. The main goal of this form of non-invasive ventilation is not to have normal gases, is not to make the baby more comfortable, is to prevent intubation and mechanical ventilation. Now, we know very well the mechanism by which CPAP helps to protect the lungs, as we mentioned before. We don't exactly know how NIPPV works. We know by several studies that compared to nasal CPAP, NIV might increase medial ventilation and tidal volume, may reduce thoraco-abdominal asynchrony, may also decrease the work of breathing compared to nasal CPAP, also may provide a better oxygenation compared to CPAP, also is more effective in decreasing central apneas through the stimulation of airway receptors, and also by splinting the airway in a more efficient way may have more effect on decreasing the number of obstructive apneas through the splinting of the airway. Now, the nasal interfaces that we use for non-invasive ventilation are the same interfaces that we use for nasal CPAP. The most common one is the short binasal prongs that have been shown to be significantly more efficient than a single nasopharyngeal tube. That's why a single nasopharyngeal tube is not used anymore. And the short binasal prongs are the choice for interface for any type of nasal CPAP or non-invasive ventilation. Now, these short binasal prongs, there are many types. One is the Hudson prongs. These prongs are quite heavy, quite bulky, and they're very difficult to maintain in place, and it causes significant nasal trauma and requires a lot of work from nurses to keep it in place and avoid trauma. So it's not very commonly used anymore. Also, the Argyle cannulas are softer, smaller, but again, they have significant increase in resistance, and that's why they're not ideal interface for non-invasive ventilation. Now, the flow generator interface was designed to decrease the work of breathing by using the choanal effect during inspiration and the fluidic change on expiration that will allow the mean pressure to remain significantly more stable throughout the respiratory cycle, and also to decrease the resistance that will therefore decrease the work of breathing for the infant. The flow generator, the most common ones are the infant flow and the Arabella. Now, there are also a new interface that was developed several years ago. The RAM cannula was developed in California. This is a very small interface that is unique in a way that the two tubes that connect the white piece with the nasal prongs only have inspiratory flow. So it's also called dual inspiratory loop cannula. And the beauty about this RAM cannula is that it's very easy to put in the baby's nose, very easy to maintain in place, allows good interaction between the nurses and the baby and the parents and the baby, facilitates also feeding, and it causes less trauma than all the other short nasal prongs. Now, the disadvantage of the RAM cannula is that it has significantly more resistance to flow compared to the short binasal prongs, and therefore sometimes we need to use a higher pressure to be able to overcome that resistance. The RAM cannula can be used for CPAP, for non-invasive ventilation, and also for high-flow nasal cannula. Finally, we have the nasal mask. The nasal masks were also developed to decrease the nasal trauma caused by the nasal prongs. It's also a mode that we can interchange with the nasal prongs to decrease the amount of nasal trauma. Nasal prongs, nasal mask cannot be used until now. There is no data for that can be used for non-invasive ventilation. So the nasal mask can only, for the time being, be used for nasal CPAP only. Okay, so what are the most common modes of non-invasive ventilation? As we said before, the CPAP is the most basic form. There are three most standard ways of giving CPAP. One is the bubble CPAP, which is the most simple and most economical way of delivering CPAP. The second one is the ventilator CPAP that can be used with any ventilator that you have in your unit. And the third one is the variable flow CPAP that allow to use the Quanell effect and the fluid exchange, as we explained before. Now, if you were to compare these three forms of CPAP, all the studies have shown that there is no significant differences. Although they are different, there are no significant difference in outcome between these three modes of CPAP. So I will not recommend any one of these in particular. And I don't think you need to go and change the CPAP you're using in the unit, trying to find a better one, because again, as I said before, the study have not shown that there is significant differences in outcomes between these three forms of nasal CPAP. The other form of non-invasive ventilation is the NIPPV. This is the non-synchronized form of non-invasive positive pressure ventilation. These are superimposed breath to the background of CPAP or PEEP. This NIPPV could be synchronized. It's called NSNPPV, or not synchronized. The synchronization of the NIPPV can be done by capsule, which is located, usually we locate the capsule, pull up the capsula in the abdomen, try to be triggered by the baby's inspiratory efforts, and also triggered by flow located at the level of the nose. The synchronization by capsule is not available anymore. It was pulled out of the market. The reason for that, it was never very sensitive and it was not very accurate. So the synchronization was never very well achieved with the capsule only. Now the flow synchronization seems to be much better. They're still developing better system that will improve the efficacy of the synchronization with flow. The disadvantage with the flow synchronization, it requires an extra dead space that may sometimes influence the level of CO2. And finally, we have the NIPP that is non-synchronized. And as I said, this can be used with any ventilator that you have in your unit. In the same form that you use with endotracheal tube, can be used with a nasal interface. Now, what are the disadvantages of NIPP? I'm not going to go over all the studies because Dr. Ram very elegantly showed those results for us in the previous session. So I'm just going to summarize what the literature has proved or shown about NIPPV. First, we know by meta-analysis done by Cochrane in 2016 that NIPPV reduces the rate of respiratory failure and intubation among preterm infants with RDS compared to nasal CPAP. In another meta-analysis done by Cochrane in 2017 showed that NIPPV reduces the need for reintubation when compared with nasal CPAP. So the first one is used as a primary mode for respiratory distress. The second one is used as a secondary mode to prevent reintubation. We also know that by the study done by Kripalani, published in New England Journal of Medicine in 2013, this is the only study that actually looked at a large number of babies looking at long-term outcome, showed that NIPPV does not improve the outcome of death or BPD when compared with nasal CPAP. Now, after I said that, however, this study, most of the centers use the CPAP or bilevel CPAP and was not a true form of NIPPV. So, that's something that needs to be taken into account. Now, there's no question that trying to synchronize this positive inspiratory breath will definitely improve alveolar ventilation. When you're using non-synchronized positive pressure ventilation, only 20 to 30% of those breaths are actually synchronized by chance with the baby's own respiratory effort. The other 60, 70%, 80% of the breath are non-synchronized, meaning that you're going to be delivering this breath either when the airway is completely closed or when the baby is expiring. And the problem with that is that it may cause significant intrathoracic pressure and may also cause inhibition of breathing. So that's the problem with non-synchronized NIPPV. With synchronization, you try to deliver that breath when the baby's already taking the breath. So you want to deliver that breath when the vocal cords are open, and that will increase the transpulmonary pressure because you're adding the negative pressure triggered by the baby with the positive pressure delivered by the synchronized NIPPV. And that should improve alveolar ventilation. Now, studies have shown that synchronized NIPPV improve ventilation, gas exchange, and reducing breathing effort when compared to NIPPV. Also provides the infant the ability to vary his or her own respiratory rate without the interference from the ventilator. And also we know that decreases the airway resistance by maintaining the coordination of the airway dilator muscles and the diaphragm. Now, having said all this, there is no trials that have compared head-to-head SNIPPV with NIPPV in important. So all these are theories, physiological statements, but again, we don't have any data to support a better outcome with SNIPPV compared to NIPPV. There is no trial also that have examined the accuracy of synchronization devices in NIV. And finally, there is no trial that have properly evaluated the advantages of synchronization during nasal ventilation. So these studies needs to be done, and we'll be looking forward for those results. Okay, what other form of NIV people are using? The other one that has become very popular is the heated, humidified, high-flow nasal cannula. This form of non-invasive ventilation has become very, very popular all over the world, especially in North America and many states, because of its easy to use. The nurses love it. The parents love it because all of a sudden you have complete access to the baby's face. It's much easier to the baby to be fed when you are using high-flow nasal cannula compared to a regular CPAP or NIPPV. And cause less nasal trauma. Now, what's evidence for using a heated, humidified, high-flow nasal cannula? And again, if you're going to use high-flow nasal cannula, you need to be sure that it's heated and it's humidified. Otherwise, it's not acceptable. Now, what are the possible mechanisms of action for high-flow nasal cannula? First, it provides a distending pressure similar to CPAP, although this pressure, as I'm going to mention later, cannot be measured. It's not measured as we do with CPAP. Second, produces a dead space washout, which the CO2 may go down because of that. Third, because of the high flow, may decrease inspiratory resistance. Now, the indication to use heated humidified high flow is either as a primary support for RDS. This is the way that this device has been used. I'm not saying that it should be used for this, but this is the way that this device has been used as a primary support for RDS, has been used to treat apnea prematurity, and also has been used to prevent extubation failure. And also in bigger babies has been used to be a form to wean the baby from CPAP into a high flow cannula before the baby goes to room air. Now, what's the main concern with high flow nasal cannula is that the amount of pressure that you're gonna get with the flow is completely unpredictable, because it does not only depend on the flow you're using, but also depends on the size of the prongs. It depends on the size of the nose, how much leak you have around the prongs, if the mouth is open or not, if there's secretions in the back of the nose or the throat. All that will influence the amount of pressure you're going to get. And it could be much, much higher or much, much lower than what you think you're delivering. So you have no way to know how much pressure the baby is receiving at any time. So the main concern is the unpredictable distending pressure. So what are the recommendations that I'm going to give you? First, only use heated humidified high flow with flows over 2 liters per minute. And usually we'll calculate about 2 liters per minute per kilo of weight. So a 2 kilo baby usually should get 4 liters per minute. The prongs should not completely occlude the NIRS. Always consider the infant's weight to set the flow rates. As I said, 2 liters per minute per kilo of weight. And again, because of the uncertainty about efficacy, safety, and lack of long-term outcome, its widespread use cannot be recommended in preterm infants. Personally, we only use high flow nasal cannula in babies that are older, over 35, 36 weeks, with some degree of residual lung disease, that are still requiring very low pressures of nasal CPAP of 4 or 5, and are already having trouble with feeding or nasal trauma. Sometimes we switch these babies to high flow nasal cannula, but when we do, or when you do switch this baby, you need to be sure that first, the oxygen requirement does not go up, that the baby doesn't become more tachypnic or the work on breathing increases before you leave the baby on high flow. If you see any of those changes, and also we look at the 24-hour oxygen saturation histogram, if you see any of these changes, you need to go back to nasal CPAP to know exactly how much pressure the baby is receiving. Another form that has become very popular over the last 10 years or so is the nasal high-frequency ventilation. There are 2 forms, as we use also the high-frequency invasive ventilation, is the high-frequency oscillator and the nasal high-frequency jet ventilator. The main difference between the two, the oscillator has an active expiration, and the jet has a passive expiration. That's the main difference between the two. I personally did not have any experience with the nasal high-frequency jet ventilation yet. All our experience here in Winnipeg has been with the nasal high-frequency oscillatory ventilation. The idea is that because we know that high-frequency ventilation produces less lung injury when you are intubated, the idea is that what about if we try to use this form of ventilation through the nose? You should maybe get less lung injury and be able to ventilate these babies appropriately. So what do we know about the nasal high-frequency oscillatory ventilation? We know that decreases the intubation rate as compared with nasal CPAP as primary respiratory support strategy in preterm infants suffering from RDS, and that was published in the European Journal of Pediatrics in 2022. We know that the nasal high-frequency oscillator may have similar effects than NIPPV in reducing the need for reintubation when compared with nasal CPAP. May also decrease PCU2 levels by improving alveolar ventilation when compared with nasal CPAP. We also know that may also decrease the rate of significant apneas when compared with nasal CPAP. And we also know that there is no difference with nasal CPAP when regards to oxygenation. So we don't usually use nasal high frequency oscillation to improve oxygenation. We only use it when we have problem with ventilation, CO2 retention, or significant problem with apneas. Now, another form, and this is the last one that I'm going to present today, is the non-invasive ventilation by NAVA. NAVA is a very fancy way of trying to synchronize the ventilator with the baby's own respiratory effort. It uses a very fancy nasogastric tube that has an electrode at the tip that is positioned just behind the heart in the lower third of the esophagus. And that catheter will pick up the activity of the diaphragm. And that electrode will determine when the contraction of the diaphragm starts, when the contraction of the diaphragm ends, but also will determine how much power, how much pressure that contraction generates intrathoracically. And that will allow the ventilator to determine the beginning, the end of the breath, the support breath, but also will determine how much support the machine needs to deliver according to the power delivered by the diaphragm. So the way it works is that the baby will initiate his or her breathing effort in the central nervous system through the phrenic nerve, will produce diaphragmatic excitation, and that will trigger the ventilator to tell the ventilator the inspiration has started. And that's when the ventilator will deliver the assisted breath. After the diaphragm has started the contraction, it will measure how much that contraction generates change in pressure in the lower third of the esophagus, how much chest wall angular expansion you get. And according to the changes in our pressure, flow, and volume, that will also send information to the ventilator to determine how much pressure, how much assist the ventilator needs to deliver according to those changes. Now, what are the pros in general with NIV? And this is for all type of non-invasive ventilation. First, we don't have very good long-term follow-up with any of these devices. Most of the study has shown very short-term outcomes. Second, we don't have still lack of commercially available, reliable, synchronized ventilators for NIV. At least not many. The success of non-invasive ventilation often depends more on the skills of the user than on the device of the patient interface. And finally, the non-invasive ventilation requires a more careful non-invasive monitoring than does the ventilator infant. One of the mistakes that we usually make in our units, and usually is triggered by nursing, is that as soon as the baby is extubated, the baby goes from having 1-to-1 nurse to having maybe one nurse for 2 or 3 babies, just because the baby is extubated. In these small babies, the nursing time that these babies require to be properly ventilated with non-invasive ventilation usually is more than when the baby is intubated and more stable intubated. So I'm going to summarize the benefits and the risk of each form of the non-invasive ventilation that we discussed before. For nasal CPAP, we know that improves VQ mismatch and oxygenation by improving FRC. We know that maintains FRC, decrease atelectasis, and also decrease the work of breathing. The risk of nasal CPAP causes nasal trauma, but also depends on the type of interface you're going to use. It predisposes to air leaks, causes gastric extension. The high flow nasal cannula, its benefit is that it has a very good nursing and parental acceptance because of the access to the face of the baby. It's easy for nursing care and acts similar to CPAP, delivering pressure, although as I said before, that pressure cannot be monitored or known at any particular time. And same as CPAP, it may cause gastric extension. The risk of high flow is, as I said before, you have no idea how much pressure you are using at any particular time. And the distended pressure can be either too high or too ineffective. Now, with NPPV, the advantage is that improve gas exchange and oxygenation. So it works not only oxygenation, but on ventilation, controlling CO2. Same as CPAP, maintains FRC, decrease work of breathing, and as we know from many studies, show that decrease the need for invasive ventilation. The risk with NIPPV, it causes nasal trauma. Again, depends a lot on the type of interface you're going to be using. Causes air leaks, and also as CPAP may cause significant gastric distension. The nasal high-frequency ventilation, we know studies have shown that decrease the number of apneas and DSATs, improves ventilation. The risk we have limited data regarding efficacy with both forms of high frequency, either jet or the oscillator. And also we have limited data in terms of safety. With NAVA, we know that is the ideal form of synchronization by synchronizing not only inspiration, but also expiration and how much support the baby needs according to the diaphragmatic contraction. We know that improves patient comfort because of that proper synchronization, and decrease peak inspiratory pressure because of the proportional assist that delivers. The risk is that first, we have very limited data regarding efficacy, and we also have very, its use is very limited to extremely low birth for infants with immature respiratory control. And it's a device that is expensive and not easily accessible to anybody. Now, I'm going to give you, just to finish, an algorithm that we use here in our center to determine what to use on any particular case, on a particular baby. So when you have a baby that has a mild lung disease with an intact respiratory drive with no significant apneas, usually we extubate that baby to a nasal CPAP. We use a PEEP that is usually 1 centimeter water higher than the PEEP that baby was needed when he was intubated. If the baby has a moderate to severe lung disease with unstable respiratory drive or has failed previous extubation to nasal CPAP, we extubate that baby to either NIPPV. Here right now we have synchronized NIPPV, or nasal high-frequency ventilation. Right now we use the oscillator. Now, the reason I put the two modes is because we have 2 units in the city, and one unit is more comfortable with one, and the other unit is more comfortable with the other. And again, because there is no head-to-head comparison between the two, we allowed each unit to use whatever they feel more comfortable with. Now, the settings that I put in there, I think Dr. Ram already went through these settings. For NIPPV, we use a PEEP that is usually 1 centimeter water higher than the PEEP used when the baby was intubated. The delta P should be between 7 and 10 above the PEEP. The inspiratory time, there's a range. If you're going to use NIPPV, if you want to maximize synchronization, you have to use a shorter TI to maximize that synchronization. Usually the manufacturer recommends 0.35 to 0.4 seconds. If you're going to use non-synchronized, I will suggest you use a longer TI of 0.5 seconds. The rate is also important if you use synchronized versus non-synchronized. If you're going to use synchronized NIPPV, you need to use lower rates to facilitate synchronization. If you're using non-synchronized, you should go higher, 30 to 40 breaths per minute. The settings for the nasal high-frequency oscillator, we use a mineral pressure that is 2 centimeter water higher than what the mineral pressure was when the baby was intubated. We use 1.5 to 2 times the amplitude, 1.5 to 2 times the mineral pressure, that's the amplitude, and the frequency that we start with is around 8 hertz. So if this baby that was extubated to CPAP tolerates that well, we start weaning the CPAP using daily oxygen histograms, clinical response, and if you have, you can also use lung ultrasound to see if you are losing volume or not. If the baby does not tolerate being extubated to CPAP, despite optimization of caffeine and maybe going up on the pressures because the FiO2 goes up, because the babies are having more apneas or having CO2 retention, then we switch those babies to either NIPPV or high-frequency nasal ventilation. Again, to be able to wean this baby from NIPPV or nasal high-frequency ventilation, we use oxygen histograms, we use the clinical response, we use blood gases, and if you have, we also use lung ultrasound. So, take-home messages for NIV. Available evidence suggests that NIPPV is superior to nasal CPAP for primary and post-extubation respiratory support, and that heated, humidified, high-flow nasal cannula is inferior to nasal CPAP and is not recommended for primary use for RDS. Only short-term benefits have been observed with NIPPV, so we need more studies looking at long-term outcomes. Flow trigger SNIPPV and NAVA triggers seem to be the best tools for synchronization. And finally, as I said before, the success with NIV depends greatly on the skills and commitment of the caring personnel. Thank you very much.
Thank you so much, Dr. Alvaro, for this great talk and comparison between all the non-invasive ventilation modalities out there. For now, we're going to switch to a different subject with Dr. Yasser Al-Sayed, who's going to talk to us about the use or the utility of near-infrared spectroscopy in monitoring infant at the transitional period. So probably most of you know Dr. Al-Sayed. He is an associate professor in Manitoba, Winnipeg. He is a neonatologist and also a researcher within the Children's Hospital of the Children Hospital Research Institute in Manitoba. And as you will hear him talk, and maybe you've heard him before, he has a great passion towards hemodynamics and monitoring of infants at the bedside, integrating pathology and physiology, and that's his main area of expertise and also research. He's also the co-chair of the POCUSNEO platform. So welcome, Dr. Al-Sayed, and take it from here. I think just moving, yeah.
Thank you very much, Dr. Ben Fadel, for the kind introduction. And I hope that you can see my slides. Can you see the slides?
No, yeah, sir.
Not yet.
Can you see now?
You can try one more time, please.
No, not yet. Are you sharing the whole screen or the PowerPoint?
Let me try again. Entire screen.
Yep.
Okay.
Yes.
Okay. Is it clear now?
Can you hide? You know, there is a message down. Stop sharing and hide. Can you hide?
Okay.
And then, yep. Thank you.
Okay, welcome everyone. Today, my presentation is about near-infrared spectroscopy during postnatal transition in preterm infants. So it is one of the main indications of using NIRS in our NICU. I have nothing to disclose in this presentation. And I have 6 main objectives. At the end of this presentation, the attendees will be able to answer these questions. So I have my objectives as answer of these questions. First question, what specifically do we need to monitor during the transition, which is a very specific critical period for any preterm infant, because during that period, the infant might develop a significant IVH, which might affect the his entire life. Second question to be answered, what are the stages of blood flow and autoregulation during the transition? We need to understand the physiology behind the blood flow. It changes during the transition. And by having this kind of knowledge, we'll understand how IVH develops. And then how do blood pressure and carbon dioxide affect autoregulation? we'll get to know eventually that these are the two main factors that might induce development of IVH: fluctuation of the blood pressure and or fluctuation of the carbon dioxide. And then the question number 4, what is the role of NIRS integration in monitoring cerebral blood flow? And how does IVH develop? And can we prevent it? And then the last question for today that we'll try to answer clearly: how do you use the near-field spectroscopy checklist with case scenarios? If you have the checklist, how to use it in systematic manner to know what's going on, if there's any changes happening on the cerebral oxygen saturation during postnatal transition. So I have 6, as you can see, 6 questions to be answered. The first 3 questions related to physiology. So even if you are not using near-field spectroscopy in your unit, that's fine. At least you need to understand the physiology of the cerebral blood flow. If you have near-field spectroscopy or you have a plan to use it in the future, then the second part of the presentation will be focusing mainly on the clinical use and integration and how to benefit from using this kind of integration to understand the physiology of autoregulation and the changes in the cerebral blood flow. So let us start with the first question. What specifically do we need to monitor during the transition? And again, the first part of this presentation is focusing on the physiology. The first half of the presentation is physiology to answer the first 3 questions. And the first question about why we need to monitor the cerebral blood flow. We must monitor the optimized cerebral blood flow during postnatal transition for one important reason: to prevent development of IVH, which is in a lot of situations is preventable, can be prevented. And we need to understand first the physiology of the cerebral blood flow. As you can see in this slide here, the brain, you have factors that might be associated with increased cerebral blood flow or increased cerebral pressure, because the cerebral blood flow is based on the cerebral perfusion pressure, or the mean blood pressure minus the intracranial pressure, which is really a small number. So we can assume that the intracranial blood flow is basically dependent on the mean blood pressure. So factors associated with increased cerebral blood flow can be sudden increase in the blood pressure, and in a lot of situations that can be induced by the physician using a lot of cardiovascular medications unnecessarily, or using extra fluids unnecessarily, or excessive handling or painful stimuli. And I think we all know the value of minimal handling policy during the early postnatal transition in preterm infants less than 28 weeks. Can be hypercarbia. Hypercarbia is very strong cerebral vasodilator. It can significantly increase the cerebral blood flow. And poor autoregulation, if there is any significant or mature autoregulation, which is common in premature infant, that might make the cerebral blood flow easy to vasodilate and flood the brain with more blood. On the other hand, we may have factors associated with a decrease in cerebral blood flow. So sudden decrease in the blood pressure, like in postnatal hemodynamic instability, either vasodilatory shock or vasoconstrictor or cardiogenic shock, or related to, on top of that, to significant PDA shunt, hypocarpia, poor autoregulation, and high intracranial pressure or mean air pressures. So if you are applying too much PEEP or too much mean air pressure, that might be transmitted to the intracranial pressure and cause significant impact on the cerebral blood flow. So which one of them might be responsible for development of IVH? So typically, the fluctuation between both is the most responsible factor. Fluctuation of the blood flow from low to high or from normal to high, which might be associated with reperfusion and sudden increase in the blood flow of the brain on the end of the second day or the third day of life. Now we have the first conclusion or conclusion number 1, which is fluctuation of the cerebral blood flow and reperfusion induces IVH. So after each question answered, we have a specific conclusion. And at the end, we have 6 conclusions related to the 6 questions. Now we'll move to the second question. What are the stages of the blood flow and autoregulation? We need to understand the autoregulation physiology during transition. And we need to know how to monitor the autoregulation at the same time. I think, as you know, the oxygen delivery, which is the main aim of maintaining the blood flow, to maintain oxygen delivery, is a function of the 3 main systems. The respiratory system to get the hemoglobin oxygenated, the blood or the hemoglobin to get the hemoglobin saturated with oxygen, and the oxygen dissociation curve with the normal value of the curve, not significantly shifted to the right or significantly shifted to the left. And then the cardiovascular function to maintain the normal blood flow or cardiac output. And everything here should be maintained with the normal temperature, normal pH, normal glucose, and normal electrolytes. And if the function of the oxygen delivery lost or the oxygen delivery decreased, then we may have the first autoregulatory mechanism, which is the autoregulation or hypoxic vasodilation. And autoregulation might work within a fraction of a second, might work very quickly. And the autoregulation, there is a limit for the autoregulation to work. If the autoregulation exhausted or not working anymore, the next mechanism to work is increase in oxygen extraction. So the tissues will extract more from the venous compartment to compensate for the low blood flow or oxygen delivery. In this situation, you will see the near-field spectroscopy number or the cerebral blood saturation on NIRS is decreasing. In situation 1, when the autoregulation is still working, you will see the number is with a normal value without a change. But once you see the number is decreasing on near-field spectroscopy or cerebral oxygen saturation, you know that the autoregulation has been lost or exhausted. And now we have the second mechanism, which is increase in oxygen extraction. If the extraction reaches the maximum and the oxygen delivery is really very low, normal oxygen delivery between 20 to 40 ml of oxygen per kg per minute. If you have a single digit like less than 10 ml per kg per minute of oxygen delivery, this might induce anaerobic metabolism. Then we'll start to see lactic acid in the blood gas, which is actually late, because this is one step before development of end organ dysfunction. Variability of any vital sign, variability of the blood pressure, heart rate, oxygen saturation is acceptable as long as the variability is within the upper and lower limits of autoregulation. Once we have the variability is exceeding above or below the autoregulation threshold, then we'll start to see the oxygen delivery is affected. So we may see the increased oxygen extraction, as I explained, if the oxygen delivery or the fluctuation of the blood flow, fluctuation of the blood pressure or heart rate is outside the autoregulatory mechanism. Then we'll see increased oxygen extraction and low oxygen delivery. Or we may see the opposite, decreased oxygen extraction if the fluctuation is above the upper limit of autoregulation. For example, you are delivering too much oxygen or giving too much oxygen as FiO2 to the tissues. And that might increase the risk of hyperoxia. So we know now the limits of near-field spectroscopy that we're using, generally between 60 as a lower limit and 80 as a upper limit, but we have centile values. In very premature infant during the first or second day of life, we may accept as low as 50 to 55 as a lower limit and 80 to 85 as an upper limit. And that might change over time. So with the low value of the cerebral oxygen saturation on near-field spectroscopy, we may expect commonly during postnatal transition either hypocarbia which is really bad and might significantly decrease cerebral blood flow, low blood pressure, anemia, or hypoxemia. And then on the upper side, if you have the cerebral oxygen saturation higher than the upper target or upper limit, that can be related to hypercarbia, high blood pressure, brain injury, or hypoglycemia. So now we have a conclusion number 2. Fluctuation within the limits of autoregulation is normal. So not any fluctuation of the blood pressure, by increase or decrease, or heart rate or oxygen saturation. When you see the oxygen saturation is fluctuating for a short period of time, that might be tolerated very well by autoregulation. So not any fluctuation or a change in numbers might be considered as abnormal. So there is normal limits that we may consider for autoregulation for any vital sign. Now we'll come to the question number 3. How do blood pressure and carbon dioxide? These are the 2 main factors that might affect autoregulation: blood pressure and the carbon dioxide. The 2 factors that might be responsible for development of IVH, as I will show you from our research studies. We need to understand first the intracranial pressure waveform. So the intracranial pressure waveform is, as you can see here, the wave is slightly increasing and decreasing in waves within like single-digit number between 7 to 9 or 5 to 10 millimeter mercury. Usually does not exceed single-digit number. And if you magnify any wave here, you will see a big upflexion, positive upflexion of the wave, which is consistent with respiratory pulse. Respiratory pulse means changes in the CO2 during breathing. And then there is very small changes related to cardiac pulse. I think now we can understand that the impact of CO2 on intracranial pressure, which might induce IVH, is much higher than the impact of blood pressure. So the cardiac pulse here, which is consistent with the pulse pressure, a change between the diastolic and the systolic blood pressure difference, the pulse pressure causes slight fluctuation of the intracranial pressure with each pulse or each heartbeat. And we have a bigger change with the breathing related to the changes on the CO2. As you can see here in the monitor, you have fluctuation of all of the vital signs. Fluctuation still within normal, it's okay, including heart rate, oxygen saturation. CO2, you have a fluctuation which is consistent with the fluctuation that we may see in the intracranial pressure here. And then slight fluctuation in the blood pressure related to the changes and the slight changes in the pulse pressure. So how the IVH develops, that's very important to understand and to know the development of IVH during postnatal transition in relation to the blood pressure. So I have a slide related to fluctuation of the blood pressure based on our data, which is not yet published, and the fluctuation based on the IVH based on the fluctuation of the CO2. In relation to the blood pressure, during early transition, just after birth, the infant, usually the preterm infant, usually born with low cerebral blood flow, with poor autoregulation and high hypoperfusion stage. At this stage, there is no problem. The brain might tolerate that without any issue in most of the situation, without need for cardiovascular drugs. The issue is when the blood pressure improved significantly, either by itself in the second day of life or third day of life with improved autoregulation, or induced by use of cardiovascular medication like dopamine or dobutamine or epinephrine, that might cause significant reperfusion and rupture of the small, tiny capillaries in the germinal matrix, which induce IVH. So the autoregulation, as you can see here, just to explain more about autoregulation, you have the x-axis here is the cerebral CO2 or the blood pressure fluctuation, and the y-axis is the cerebral blood flow. So you have here area of plateau with hypocarbia. You may see some slight change or vasodilation during the, or no change at all during the plateau phase, but the hypocarbia might be associated with decrease in the cerebral blood flow once the hypocarbia is beyond the autoregulation threshold, which is around 30 to 35 milliliter mercury of CO2. And the opposite was hypercarbia. The hypercarbia might be tolerated within the autoregulation, but once the autoregulation reaches the maximum, then hypercarbia will be associated with more vasodilation and more increase in cerebral blood flow. The same with hypotension. With hypotension is well tolerated during the autoregulation threshold, but not well tolerated beyond the autoregulation threshold. Either low blood pressure will be linearly associated with low cerebral blood flow, or hypertension will be linearly associated with higher cerebral blood flow. Unfortunately, the autoregulation in premature infant is very limited, especially early postnatal transition period, which might be contributing to development of IVH. So the relationship between cerebral blood pressure and cerebral blood flow is almost linear. Matures a little bit beyond the transition, especially for premature infant, more than 23 weeks. For 22-23 weeks, they have almost linear autoregulation, even beyond the postnatal transition period, the first 3 days. This plateau phase will mature over time with corrected age of term, and then by 1 year, it will be almost close to the adult maturation of autoregulation plateau, will be much wider. So we have now the conclusion number 3. Conclusion number 3, the main factor of sudden change in the cerebral blood flow is the fluctuation of the carbon dioxide as a main factor, even much more important than the fluctuation of the blood pressure. So keep in mind that the development of IVH might be related to sudden changes that might happen in the ventilation during postnatal transition period. Now we'll come to the part 2 of the presentation, the clinical application, how to apply whatever we know now from physiology at the bedside. And by that, we'll answer the question number 4, what is the role of NIRS, near-field spectroscopy integration in monitoring cerebral blood flow? We are routinely monitoring the arterial oxygen saturation by pulse oximetry, which is only 15% of the circulation, and we are ignoring 85% of the circulation, because our circulation, we have only 15% in arterioles or arterial, and 85% of the blood volume in the venous compartment, which is not, we are not really monitoring if we don't have this technology, the near-field spectroscopy. Near-field spectroscopy monitoring the regional saturation for the brain or any other specific organ, and it is not required, the pulsatile flow or the arterial flow not required to obtain reading, which is necessary for pulse oximetry. Without having pulsatile, good pulsation or good perfusion, you cannot rely on pulse oximetry oxygen saturation or arterial oxygen saturation. Now we'll come to this very important slide from our unpublished data, will be published soon, to explain how the IVH develops with the fluctuation of the blood pressure. So in this graph here, you have the blood pressure as you can see here. Sorry, this is a fluctuation of the CO2 and the fluctuation of the blood pressure at the same time. So we have the blood pressure here or mean blood pressure in the purple line with a slight increase, as you can see, and the CO2 in the lower red line, and the cerebral oxygen saturation in the blue line, and you can see the hemoglobin as detected on the blood gases in the top red line. So here you have 1, 2, each interval here is a 6 hours. You have 6 multiplied by 8, we have the first 72 hours, the first 3 days after birth. So you have each period interval here is about 6 hours, and we have done the blood gases almost every 6 to 8 hours. So as you can see here, the CO2 slightly decreased after a period of time after the first day of life or second day of life. There is a sudden increase in the CO2, which was associated with increase in the cerebral blood flow, and that was associated with a sudden drop after that, or shortly after that, with the hemoglobin due to development of IVH. So IVH happened here, and that was confirmed on the second day by cranial ultrasound. In this example here, the fluctuation of the CO2 was even more significant, more than the blood pressure, and that was associated. The blood pressure did not change significantly. In the previous slide, both of them changed. So the blood pressure did not change, only CO2 increased significantly, and that was associated or later on or followed by significant decrease in the hemoglobin, signifying development of IVH at this time, almost end of the second day of life, and that was confirmed after that by cranial ultrasound. So the sudden increase in the CO2 on the previous slide, sudden increase in the blood pressure, and sometimes also CO2, increased the trend of the cerebral oxygen saturation, signifying sudden increase in the cerebral perfusion pressure or the cerebral blood flow. So by having the near-field spectroscopy, CO2 and blood pressure, plus frequent blood gases, I can tell you when the IVH happened. I'm talking about the severe IVH, grade 3 and higher. There's another study here signify that or highlight that if you have more than 20% difference in the CO2, that was associated with significant increase in the intracranial pressure and the development of IVH. Also highlight that fluctuation of the carbon dioxide was a significant contributor to development of IVH. Now we have a conclusion number 4. I need a blood pressure near-field spectroscopy CO2, and CO2 can be either transcutaneous CO2 monitoring or by frequent blood gases, and then I can confirm the timing and mechanism of IVH. Was it due to CO2 only, or blood pressure, or both of them? In most of the situation in our data, it happened because of both blood pressure increase and CO2, or CO2 by itself without any change in the blood pressure. Now we are going to answer the question number 5. How does IVH develop? And we partially answered this question, and can we prevent it? In this preterm 24-weeker dropped hemoglobin at day 1 of life, and the day after that we did cranial ultrasound. As you can see here on the right side, there is significant IVH, and also there is periventricular hemorrhagic infarction. We applied this autoregulation calculator, which is not yet published. In this calculator, I used the blood pressure values, the highest value and the lowest value, which I assumed before and after a change in the hemoglobin, which is assumed to be the time of development of IVH. In this 24-weeker, the first day of life. So there is sudden increase in the blood pressure trend, as you can see here, 58 mean blood pressure to, the sudden change in the cerebral oxygen saturation from 58 to 82. Although both numbers are within normal, but there is more than 20% change in the trend. And that was because of significant change in the trend of the CO2 from 42 to 76. This trend was associated, as you can see from the calculator, with high cerebral blood flow. And that might be the contributing factor for the development of IVH. Sudden increase in the cerebral blood flow, secondary to sudden change in the carbon dioxide trend. When we studied the group with absent severe IVH, you can see here there is no significant fluctuation, only minimal fluctuation in both blood pressure, just linearly increase, which is expected during the first 3 days of life. You can see the blood pressure gradually increases, But the CO2, there is minor fluctuation, was not associated with significant fluctuation in the cerebral oxygen saturation. And the hemoglobin only slight change over time. So how to protect the brain, or protective brain strategies to avoid harmful intervention? We need to avoid harmful interventions to protect the brain. So prevention of reperfusion injury, avoid unnecessary fluid boluses, prevent fluctuation of the blood flow, avoid cardiovascular medication whenever possible, prevent fluctuation of the carbon dioxide, avoid aggressive ventilation during the first 3 days of life. If you are able to maintain ventilation with non-invasive ventilation, that would be the best. So don't try to wean too much or change ventilation significantly once you stabilize ventilation during the first day of life. Delayed cord clamping is very important. Very important to allow the first breath to be taken while the cord is still contact. The lung is like a sponge. Once you inflate the lung significantly, the lung will get or will help to shift more blood through the placental circulation through the umbilical cord. If you consider delayed cord clamping while the infant is not breathing yet, that might not be really helpful. Or you cut the cord before the first breath. So the best to get the first few breaths while the cord is still connected. Then the lung will inflate, the pulmonary arterial pressure drops, and that will absorb, that will get more blood transferred through the umbilical lines from the placental circulation. Now we have the conclusion number 5. We're getting close to the end. To prevent IVH, consider the combination of antenatal steroids. You have to be sure that the antenatal steroids given an appropriate time before delivery, and that can be repeated if you have more than 2 weeks interval before the first course and the delivery. Delayed cord clamping, avoid aggressive ventilation during first few days of life, and avoid sudden blood pressure changes. Now we have the question number 6, last question in this presentation. How do we use near-field spectroscopy checklist with case scenarios? This is a checklist, a near-field spectroscopy checklist that was developed in our hospitals. And this checklist, you have very clear to the bedside nurse, to the RT and the physicians, when you have sudden increase in the cerebral oxygen saturation above the baseline, and above the baseline by 20% is significant. Even if you have both numbers before and after, they are within normal, but you have more than 20% difference, then consider that could be related to you are giving too much oxygen, that you have to wean, brain injury and HIE, hypoglycemia, polycythemia, hypercarbia, or over-sedation or anesthesia. When you have the opposite, decrease in the cerebral oxygen saturation below the baseline by more than 20%, it could be hemodynamic instability related issue like hypotension, shock, low systemic blood flow due to any reason, low oxygen saturation, or anemia, hypocarbia, or lung overinflation. You have to decrease the mean air pressure or PEEP, or brain compression like in developing hydrocephalus. And the intervention is related to all of the list items in the checklist. So you may increase or decrease FiO2, reduce mean air pressure if possible, optimize lung inflation. You may consider echocardiography, target neonatal echo, to assess for hemodynamic instability. Cranial ultrasound if you have unexplained low brain saturation, and we have done that many times, and we discovered there is ongoing hydrocephalus related to low brain blood flow. Check the blood pressure, check perfusion index. So you may have vasoconstrictor physiology, poor peripheral perfusion reflected on perfusion index. Check blood gases for pH, CO2, and hemoglobin, because increase or decrease in carbon dioxide, as we explained, significantly impact the cerebral blood flow. And then check blood glucose level, because hypo or hyperglycemia might affect the cerebral blood flow as well. As you can see here, you have this infant with low CO2 and tidal CO2 with associated at the same time with significant decrease in the cerebral blood flow, and that can be corrected in real time. When we apply the same to the calculator, we have this calculator available on the website, available for free. You need just to enter the age in hours, gestational age, the pulse oximetry number, and the cerebral oxygen saturation. And the calculator will let you know what you need to do for the first next step. So in this example here, you have less than the 5th centile for the cerebral oxygen saturation and the high fraction oxygen extraction. And that was because of low CO2, because the calculator asked you to do blood gases and check for CO2 level. In this example here, we have significant change in the blood pressure after unnecessary bolus of normal saline given, and that was associated with increase in the cerebral oxygen saturation. This is harmful, and this might be associated with IVH. Again, you may have this calculator. This calculator is not available yet, but we are using to assess the autoregulation when you have significant change in the cerebral oxygen saturation, and apply the blood pressure before and after the change. And you can detect there is high trend change in the blood pressure, and that this is dangerous. This high increase, sudden increase in the cerebral blood flow might induce IVH. Again, you have this calculator that was used in this case scenario. In this premature infant, 28 weeks, more than 72 hours of age. Cerebral oxygen saturation dropped to 45, although the pulse oximetry was normal. And that was explained that could be due to change in the blood pressure CO2, or you may need to do echocardiography or brain ultrasound. CO2 was normal, and there is no overdistension or high mean pressure, overdistension of the lung or high mean pressure, no anemia. So the calculator is asking you to check hemodynamics by applying more detailed assessment of the blood pressure, perfusion, and maybe echocardiography. In this article, we published the integration, how to use near-field spectroscopy with other hemodynamics parameters to understand more about the ongoing hemodynamic issue. So now we have the conclusion, number 6, and the last conclusion in this presentation: bedside checklist of integrated evaluation of multimodal monitors is effective in real-time assessment of the cerebral blood flow. This in case of you have perfusion, you have blood pressure, you have CO2, plus near-field spectroscopy, you can understand the changes happening in real time in relation to any one of these vital signs and the impact of that on the cerebral blood flow. So now I answered the six questions that led to 6 conclusions. Fluctuation of the cerebral blood flow and reperfusion induces IVH. Fluctuation within the limits of autoregulation is normal. The main factor of the sudden change in cerebral blood flow is the fluctuation of the CO2 and the blood pressure. I need blood pressures, near-field spectroscopy, CO2, and the frequent blood gases, and I can confirm the timing and mechanism of IVH. To prevent IVH, please focus on antenatal steroids, delayed cord clamping, avoid aggressive ventilation, and sudden blood pressure changes. Bedside checklist, well-organized checklist of integrated evaluation of multimodal monitors is effective in real-time assessment of the cerebral blood flow. And thank you very much. Happy to listen to your questions and comments.
Thank you so much, Dr. Al-Sayed, for that great presentation. Always I say the brain is the most important organ, but yet the least organ we're monitoring in ICU. And having the near-infrared spectroscopy is a great tool. Couple of questions, and I will leave it to you to decide how to answer them in sequence. One question is, do we know the non-invasive ventilation, if started early, and the impact on cerebral perfusion? If I use the NIPPV in the first 2-3 days of life, especially when the risk of IVH is high, is the better to tissue oxygenation achieved with these compared to intubated baby? Do we have less fluctuation, especially the cerebral perfusion? The plateau period is quite narrower compared to term baby.
Yeah.
The second question, you mentioned in the intervention and when you alert physician about changing the baseline, if it's been more than 30 minutes, is it 30 minutes too much? Last question, it was online. Why we are using mean arterial blood pressure, not systolic, not pulse pressure in these? Thank you.
Okay, wonderful. I think 3 or 4 questions. So the first question about the impact of non-invasive ventilation. To be honest, there is no any clear answer from literature to my knowledge. And now you give me wonderful idea for research. So thank you very much. The data that we know, if you apply too much pressure, either invasive or non-invasive, regardless too much mean or pressure, that might be transmitted to the intracranial pressure and impact cerebral blood flow. So you give too much PEEP or too much CPAP pressure, whatever pressure. So we know that higher pressure is bad, but to compare between those non-invasive ventilation versus ventilated babies, this question never been answered, typically because we never consider to randomize premature babies between non-invasive to invasive and monitor the brain saturation, because that might not be applicable, because we try always to avoid intubation and to consider non-invasive as the main start ventilation modality as a default before considering intubation for any infant. But I think we may consider research to answer the question, like somewhat, not necessarily to be randomized, but to compare between those, maintain like that we are able to maintain on non-invasive ventilation versus intubated babies, and the impact of that on the cerebral blood flow and also development of IVH. In our studies that I showed you, the graphs, it is basically related to the fluctuation of CO2. Some of them get extubated and re-intubated, or aggressively weaned or aggressively increased. So the aggressive change in the ventilation during the first 3 days, that might be the most contributing factor to the sudden changes in the CO2 of the brain, which we need to avoid. That's the take-home message from this presentation. So that's the first question. Second question, related to
we're waiting 30 minutes before we interfere.
Yes. So 30 minutes is assumed period, not by evidence, not by any means, but we just try to avoid unnecessary extra or over reacting to any change in the cerebral blood flow. Because if we consider 5 minutes, 10 minutes, you may see the changes and this fluctuation that might be corrected without any intervention, which is much better than doing blood gases and adjust the ventilation or change or give cardiovascular medication to improve the blood pressure. That's why we assumed that 30 minutes might be a reasonable period to wait before we intervene. This is not absolute. You may have significant change over 10-15 minutes, and the significant drop is really significant, and you should not wait beyond that period. So this might be applicable in most of the situation, but in some situation, you may not wait until you reach 30 minutes. You may react within 10 minutes or even shorter when you have significant drop unexplained, especially when the change is associated with significant change in the blood pressure or CO2 or the other clinical vital sign. Then you have to intervene earlier. So this is the second question. Third is about the blood pressure. Why mean blood pressure?
Yeah.
So this is a very good question. Wonderful question. So typically when we look at the blood pressure for intervention, we should not look at the mean blood pressure. We should look at the systolic blood pressure and the pulse pressure, these are the two independent factors. Because systolic is a calculated number, diastolic blood plus pulse pressure. Mean blood pressure is 2/3 diastolic, 1/3 systolic. But I'm talking about the perfusion pressure. Perfusion pressure is typically the mean the driving pressure. We are using systolic and the diastolic pulse pressure when we intervene, when we treat the hypotension to understand is it vasodilatory shock or vasoconstrictor shock. But to monitor the cerebral blood flow, it is the pressure that define the perfusion is the mean blood pressure. So there is two different situations now. To understand the perfusion, we need the mean blood pressure. But to treat or intervene, you need to look at the diastolic and the pulse pressure.
So cerebral blood, correct me if I'm wrong, cerebral blood perfusion more correlate with the mean more than the systolic or the diastolic?
No, it is correlated with everything, but it is defined directly, or the equation, to be more clear, the equation of the cerebral blood perfusion pressure, it is mean blood pressure minus the intracranial pressure. Because that's a pressure that reach to the tissues at the end through the arterioles. Because once you reach the periphery, you have the difference between systole and diastole very narrow. So you have only probably one pressure, perfusion pressure, one number at the end. So it is as a physiologic pressure that determines the perfusion. But to intervene, to treat the hypotension, you need to look at the diastolic pulse pressure or diastolic and systolic pressure. Yeah, go ahead. I think maybe some question to the other speakers if you.
Dr. Ram did a great job answering most of them. But I will ask you a question and then maybe Adel can ask Dr. Ram. Dr. Alvaro, actually, there's some questions for him. So just quick question you talked about blood pressure and the mean systolic, diastolic. When you use NIRS, do you always use central blood pressure monitoring, or how reliable is the invasive blood pressure in those preterm babies in transition circulation, and how can that relate to kind of valuable result from NIRS?
Yeah, this is a very good question. Invasive blood pressure during postnatal transition, this is standard for premature babies because we use the umbilical line for sampling for monitoring the blood pressure at least during the first few days of life. That's our standard for very premature babies. And we recently published, I think, as you know, the normative blood pressure values for premature babies during postnatal transition, relying only on the invasive blood pressure. So that was the first normative data published only using invasive blood pressure. Just in case, if you don't have invasive blood pressure, that's not the end of the world. You may need to use near-field spectroscopy even more because you don't have other parameter to reflect in real time continuously the cerebral blood flow. But you can rely on the non-invasive blood pressure on regular intervals. For stable babies, you may do that every few hours. For unstable babies, and if you are considering this infant might be in shock, you need to do it frequent, and you need to look at the trend over time. So you need to do it every 10 to 15 minutes, and the cuff can be on the hand, and you can adjust the monitor to measure every 10 to 15 minutes, and you can see the intervals, and between the intervals, you can, on the monitor, you can look at the trend. And based on the trend, you will understand if the trend is decreasing or plateau is stable, and correlate that with the cerebral blood flow. So still you can use the non-invasive blood pressure to correlate with the cerebral blood flow, although it is not the standard, it's not the best.
Yeah. Okay. Thanks.
We'll switch the gear a little bit more back to the non-invasive ventilation, and one interesting question to Alvaro regarding the NAVA and what will be the effect of the hiccup when the babies have hiccup. We knew that the electrical activity comes from the diaphragm, and this is how it guides the NAVA to synchronize the breathing for. I have no idea I use NIV.
Yeah. I mean, I'm not an expert in NIV because we don't have it here. I never use it, but definitely when you have hiccups, you create significant changes in thoracic pressure that has no relationship with the contractility, with the pressure generated by the contractility of the diaphragm. So definitely, if you have hiccups and they're significant and frequent, that definitely is going to work against the synchronization with the machine. That's for sure. Because again, it may not affect the timing of the breath, but may affect the proportion of the assist because you have an extra. You have something else that is affecting the intrathoracic pressure beside the contraction of the diaphragm. So yeah.
Thank you for this question. I have another question to Dr. Alvaro on the same line with the using NIV, and I think you kind of touched this one, but need to make sure that we understand this part. We don't have enough studies to see the efficacy of NIV, especially in the extreme preterm babies, the 22, 23 weeks, 24 weeks, given they have immature control of their breathing. And this is the fundamental principle of how NIV or NIV in general work. Can you put some light if there is evidence that it will be effective in this extreme preterm babies? This is one. And also, there is a phenomenon that is not well studied in our population, neonates, which is ventilator-induced diaphragmatic dysfunction. In adults, it's well studied, it's well known. If an adult exposed to mechanical ventilation, usually the diaphragm will not be functioning normal. Where NIV will be in most of our population, where actually they are chronically ventilated patients, where the NIV will be in this population. So this is two questions regarding the use of NIV in extreme preterm babies, given they are immature, and in the chronic lung disease babies, with the possibility that the diaphragm is affected too with this mechanical ventilation.
Yeah, those are very good questions, and I don't think we have the answer for that. Definitely for extremely low birth weight infants, because these babies have very weak respiratory effort. It definitely is more difficult to synchronize properly with NIV. And the chronic use of NIV in these babies, yeah, you may have a point there. We don't have no idea. We have no studies looking at long-term effect of NIV in these babies. So those are very, very questions that we need to answer with proper research studies. Yeah, for sure.
Thank you so much. Thank you.
I have two questions for Anthem. The NIPPV on a ventilator. Sometimes because of leak, the compensation for compensation, the flow can go up to 40 liters. Is that a concern for you? And the second question, 23-weeker, 500 gram, facial mask and nasal prong are too big. Can I use the RAM NIPPV for 500 gram who's extubatable?
Okay, good question. So again, our smallest baby, we use the RAM canal as 270 gram. So there are micro or nano preemie size cannulas that are available. That's what we use in our NICU and in the delivery room. We don't have any other interface for the last 10 years. And second, if there are leaks, the leak compensation, yeah, the flow will go up. But we have tested the RAM cannula up to 30 to 40 liters per minute, and it doesn't break up, or we are not worried about that. So those are the two things. There's no limit on how much flow that can go through the RAM cannula. Yeah.
There was one question to follow up with Samir's question came in the Q&A that I felt that is interesting. Was any association, did you come across any study that looked at using this high pressure and occurrence of SIP, spontaneous intestinal perforation, giving the CPAP belly or the distended bowel to this baby?
History-wise, many years ago, Jeff Garland from Minneapolis in 1985 used the face mask and started trying NIPPV. He's probably one of the first ones to do that. And he found a lot of gastric perforation, not SIP, gastric perforation. And the mean pressure, PIP, at which the gastric perforation happened was 18. That is the reason why Harish Kiripalani's trial, he said, even if you use a ventilator, you cannot hold more than 18 centimeters. So yeah, but after that, the 12 randomized controlled trials between CPAP and NIPPV, there is no increased risk for SIP or neck or time to full feeds or feeding intolerance. The CPAP belly or abdominal distension is very similar with CPAP or NIPPV. And therefore, you have to aspirate the air in between feeds or before feeding. That's a problem. There's nothing we can do because we have an OG tube in all these babies. We open up the lower esophageal sphincter, and therefore air is going to go at the point of least resistance. So that's one problem with the non-invasive ventilation is abdominal distension from the gas.
Thank you so much.
Okay. There's a couple of questions for Dr. Al-Sayed. Is he on? Again, about NIRS. I'll just wait for him to come up.
Yes. Back.
Hi, I'm back. Couple of questions about NIRS. So have you seen, because I know you use NIRS a lot. Have you seen, and there's a question about this, have you seen that elevation of the baby's head as part of the IVH bundle, like a prevention bundle, affect NIRS in any way?
Elevation of the head in the we are not doing that. So we never did that before. Usually we keep the head midline position.
Okay.
That was straight or like flat, maintain midline. Even when we move the baby, we'll maintain the midline. And I don't think that might affect the, even if we do that, will affect the brain oxygen saturation or the blood flow. Because there is like would be a range of autoregulation that might maintain the blood flow even with the position, even with the premature babies. That's maybe a physiologic assumption, but we should not change the head position significantly during the first
the first 3 days. Yeah. Okay.
I have a question for Dr. Yasser. Can I ask you that? I'm surprised that you're keeping the baby's head flat. We use usually 15 to 20 degrees to promote the venous drainage. It's the venous congestion that increases the risk for IVH. So I was wondering why you're not keeping the head end up.
Yeah, I think what we do exactly just slightly higher. That might be 10 to 20 degrees. There's not 5 degrees that my understanding or significantly change the position.
Yeah. I think most head elevation, it's the recommendation not to go above 30 degrees.
Yeah.
Okay. The other question was, are there any NIRS indications for prevention of necrotizing enterocolites?
Yeah, this is a very good question. We are relying mainly on stunning ultrasound because you will get a lot of details in real time. The issue with using NIRS in the abdomen, you have to be sure that what we are tracing is actually the perfusion of the gut. Not you have in the abdomen, you have boobs, you have air, you have sometimes a fluid. If you have ascites related to neck, so that all of these artifacts might affect the reading. So you have to be very careful about the position of the sensor. That's why we are using NIRS after ultrasound. So assess the loops and the location of the NIRS first, and apply the NIRS just for a period of time in an interval to assess the perfusion when we need that for interventions or to maybe confer gut hypoperfusion or ischemia. Second, or adjuvant to ultrasound, not a replacement. So I don't advocate use near-field spectroscopy for the abdomen if you don't have ultrasound, because that you might get a lot of artifacts or abnormal number that might not be real intestinal ischemia. So if you have ultrasound, use NIRS adjuvant. But I'm talking mainly about the cerebral ultrasound. Cerebral perfusion assessment by near-field spectroscopy.
Right.
I think we are approaching the end of the session, the Q&A, and Dr. Ghani needs to give like close remarks for this a very interesting session. Thank you for our speaker, and Dr. Ghani, it's all yours now.
Thank you, Adel. Thank you for everyone, starting with our professors. Even though it is a holiday today, and there are a lot of guests for Professor Ram, and he has engaged with us for the last 4 hours. And thank you for your dedication. And we learned a lot from your session, and you have already cleared everyone's doubt in the Q&A section. Thank you so much, Professor Ram. Thank you, Professor Ruben and Dr. El Sayed, and for your wonderful presentations. And I would like to, it's more than thank you for conducting this event smoothly and managing these questions and the whole event. For all the panelists, Dr. Nadia, Dr. Samar Isfi, and Dr. Adil Muhammad. Without you, it would not be possible to conduct such a big event. And thank you so much for making it very smooth and interactive. And last is thank you so much for all the audience, even though it is early morning for some of you, 4 o'clock or 5 o'clock, and you are staying with us, awake and actively interacting with the learning. And thank you for everyone. And for those who had some issues with the slides or are not unable to see Professor Ram's presentation, and we will be posting the recording in the website, and we will inform you by email. Please keep in touch. And the last but not the least, please evaluate all the sessions by giving your feedback. And the feedback link is there with your email, where you got the sign-in email. And the last box is the feedback link. If not, I will be also sending an email, follow-up email within an hour with the feedback link. Please fill the feedback link and submit. And immediately you will get a participation certificate with the online CME credits. Thank you so much. And I will ask Yasser to say some few words.
Yeah, thank you very much, everyone. I think today was very, we covered very important topics, the non-invasive ventilation, cerebral blood flow, and IVH. I think they are very hot topics for everyone to know in practice in neonatology. We try to cover as much as we can questions. We have given probably more than half an hour for at the end for questions, and Dr. Ram did a great job answering most of the questions during the last like the last 2 presentations. So thank you very much for everyone being engaged with us. I think it is probably too late for a lot of countries on this, like other half of the world, the east side, probably beyond midnight now. So thank you for staying with us, and we promise to do our best to conduct as much as we can helpful educational sessions. And we'd like also to thank our sponsor today, Medtronic, for supporting this event and the platform, which is really expensive platform, to enable everyone to join for free. I hope to see everyone again in the near future with more educational events. Thank you very much.
Thank you. Thank you all, and good night for most of you. And yeah, thank you. And we will join soon in upcoming sessions, and I will inform you by email. Thank you.
Thank you.